Um, Welcome everyone, and welcome to this, the IP3D presentation. I should just briefly mention IP3D stands for Improving the Perioperative Pathway for People with Diabetes. This is a project supported by GIRFT. GIRFT stands for Getting It Right First Time. And this is, just for those who don't know about GIRFT, this was initially a project started by Tim Briggs, an orthopedic surgeon, who showed that getting pathways right and getting people to work to best practice saved a lot of money in orthopedic surgery around the country, as well as improved patients' outcomes. That project is cascaded out to other specialties, mainly surgery, and in the last 2 or 3 years, it's gone out to diabetes and medicine, and diabetes was the first of the medical specialties. So we were delighted to present our GIRFT diabetes report last November, and this is a spin-off project from some work that we've been doing in Ipswich Hospital around the pathways for perioperative care. I won't go into it any further because there are other individuals here who will describe the pathway to you. So we have Rachel Allen, who's one of our perioperative diabetes specialist nurses working in Ipswich Hospital. Kim Housen, who is a perioperative nurse, who's joined the GIRFT project from James Paget. Emma Morris, again, perioperative diabetes specialist nurse, again, a new nurse joining the project from Stockport. Claire Hamlin, who most of you will know, is primary care GP lead. Last but not least, who you can't see, is Emma Page, who's the project lead, working together with myself and the others. So that's a little bit of the introduction. Just for your knowledge, this session is going to be recorded and it will be available on the GIRFT website if you want to review it or if you want to share it with others. Finally, if you have any questions, please put them into the Q&A section of the Zoom program, and we will pick up on them at a later date. So that's enough from me, except to say, I really do hope you enjoyed this. We hope we can engage you in getting it right in primary care for people coming into hospital needing surgery, both day case surgery as well as elective inpatient surgery. So I'm going to hand over to Rachel, and Rachel will tell you what she is about.
Hello everyone, my name's Rachel and I work in Ipswich Hospital. I'm just getting my slides up. So I'm the perioperative nurse in Ipswich. I started my post 3 years ago. I was previously on the surgical wards and I was lucky enough to be seconded for 18 months to start this. So I was part-time on both to begin with. So part of the IP3D project, we were able to implement a number of innovations to improve perioperative the pathway for people with diabetes. And this included the passport itself, the diabetes surgical study days, and working within primary care to improve the quality of referrals. My role also involved me doing two pre-op clinics a week, where I was again communicating closely and more than likely electronically or over the phone with primary care to optimize the patients to come in for theatre. And it also gave us great outcomes at the end, which is fantastic. So the new pathway led to significant reduction in length of stay from 4.8 days to 3.3, and a reduction in overall post-op complications from 28.1 to 16.3%. I also, as I went along, we did some patient surveys and overall it improved the patient experience. So going on to the new DSNs in the other hospitals, we have 10 pilot IP3D sites, which have recruited a perioperative diabetes specialist nurse at each one. Their role is primarily to support the rollout of the new perioperative pathway, to provide education and support patients pre and post-operatively, to include providing pre-optimization clinics, and to improve diabetes education amongst surgical staff. So these nurses, they're being supported in training in diabetes management of perioperative patients by their local diabetes teams, by GIRFT, and via shadowing and network sessions, e-learning, coaching calls, and fortnightly one-to-one support. So I've already had the pleasure of having quite a few of them shadow me, and they all seem to be getting on brilliantly. So just to introduce them, in gallery view. We've got Bitha Sharda. She's from Manchester University NHS Foundation Trust. We've got Emma Morris, who's going to present to us shortly from Stockport NHS Foundation Trust. Danielle Bruce from University Hospitals of Leicester. Kim Howson, James Pageant University Hospital. Rachel Buckland from Hull University Teaching Hospital. Michael Grange, Portsmouth Hospital NHS Trust. Rebecca Oliver, Royal United Hospital Bath. Rosemary Enzio, the Hillingdon Hospitals NHS Foundation Trust. Talavane Puganavam, I apologise if I didn't say that right, but she's new in post, St George's University Hospital. To be confirmed is Northampton General Hospital Trust. And we also have Rebecca Oliver, you can see in front of us, Royal United Hospital Bath, and Rosemary Enzio, this picture of the Hillingdon Hospitals NHS Trust. So that's for me, and I will hand you over to Kim Howson, who's one of our new perioperative who I've just introduced.
So just before we go over to Kim, can I just break in again and just part of the introduction, we should just tell you how we came to this project. I've been working with the Joint British Diabetes Society over perioperative care for a number of years, and we produced a very good perioperative document. And it was well received by anaesthetist surgeons, but never implemented. We had real difficulty in getting people to step up to the mark for implementation. So myself and Emma Page, who you can't see here, worked on a pathway which was patient empowered. So we worked on what was called a perioperative passport that the patient can take with them to engage in perioperative care. So that's how the project came about. So back to Kim.
Thank you. So my name is Kim Howson. I'm the Diabetes Perioperative Specialist Nurse at the James Pageant Hospital. We know from national audits, such as the National Confidential Inquiry into Patient Outcomes and Deaths, that patients who've got diabetes are more likely to have increased risk of post-op complications and a longer stay in hospital, as well as inpatient harms such as hypoglycemia and diabetic ketoacidosis. The reason for this is that patients are more likely to remain hypoglycemic during and after their surgery. Any pre-existing hypoglycemia is further exacerbated by the stress and sometimes pain associated with surgery. And this all contributes to infections, poor wound healing, and for some, the complications can be far more serious, requiring a stay in intensive care. Now, each hospital has undertaken an extensive audit of patient records to identify the areas of improvement that are relevant in your local area. However, many issues are experienced across all regions. This case study is of a man who has type 2 diabetes and was referred for urology surgery. His referral did not contain mention of his HbA1c. And despite the use of auto-generated clinical information summaries by many practices, the majority of referrals that we receive do not include HbA1c, which enables prompt identification of patients at high risk of complications. Now, Mr. Jones had his procedure without optimization of his diabetes and ended up seeing his GP and in A&E 2 weeks later with wound dehiscence requiring antibiotic treatment. And sadly, the experience of other patients is that they have their operation cancelled at the last minute due to poor glycemic control. And they tell us that they were unaware and they wish that they'd known sooner so that they could have done something about it. So they're left frustrated and disappointed at delays in their surgery. In addition, many patients have experienced quite a significant rise in their HbA1c during the pandemic. And prior to the new surgical pathway, Mr. Smith had received no medications to improve his diabetes management prior to attending for ENT surgery. And despite management with insulin, he required an overnight stay rather than a few hours as a day case procedure and an insulin start. If his HbA1c had been caught picked up earlier, perhaps an SGLT2 inhibitor or GLP-1 injectable therapy could have been commenced, and the overnight stay could have been avoided. And some patients have also experienced such a decline in their renal function by the time that we see them that it actually limits the treatment options that are available. So the Joint British Diabetes Societies and the Royal College of Anaesthetists advise that the HbA1c should be less than 69 millimoles or 8.5% for safer surgery and optimal recovery. And it may be necessary sometimes to postpone an elective procedure to facilitate that improvement. More recently, the Centre for Perioperative Care has included recommendations for primary care teams, as well as ourselves, on referrals and optimisation for surgery. But overall, the benefits of the new surgical pathway are that patients are often very motivated to have their surgery, perhaps because it will make a big difference to their day-to-day life. For example, one person I've spoken to recently, they're waiting for a reversal of a stoma. Another is waiting for head and neck cancer surgery. So we have a real opportunity to engage these patients in their self-management. And often, lifestyle changes that people make for their diabetes are going to be beneficial to other health conditions as well. And it's in line with the recommendations of Royal College of Anaesthetists that it's right to think about optimising multiple conditions in advance of surgery, such as anemia and hypertension. So with improved information in our automated patient summaries or templates, or however we refer, we can better identify patients at risk of severe complications early. And this is not just about improving the patient's experience around surgery and helping them to have a recovery that doesn't involve trips to their GP or A&E for antibiotics or an extended district nurse visits for wound care. By reducing the length of stay in hospital, we're going to enable more people to have their surgery sooner. And this is particularly relevant because having had significant reduction in our surgical capacity whilst we were caring for patients during COVID last year, there's certainly a long list of patients waiting for surgery. But most importantly, some patients that we engage with are going to make lifestyle changes that have long-lasting effects on their overall health. So what does glycemic optimization look like? For some, it includes insulin starts and switches, partnership working between community diabetes nurses and GPs, encouraging patients to check their blood sugars where they haven't done previously. Though for the majority of patients seen, like Mr. White, with awareness raising, lifestyle advice, and optimization of medication, we see significant reduction in HbA1c, and he feels much better for it. So to summarize, it's up to us all to make the most of those teachable moments where we can engage patients in their diabetes management, even by simply making people aware that having good blood glucose control can improve their recovery from surgery. And even with a 2-week improvement in glycemic control, a person's white cell function can be improved. We should optimize health conditions where possible to help patients in their fitness for surgery. And for some, we're going to enable those much longer lasting health benefits. So now over to Emma.
Before we hand over to Emma, can I just encourage people to ask some questions? Please don't be shy. We've got some time at the end, and it would be really good to chat around the questions that you pose. Do you really believe that an improved HbA1c makes a difference? Maybe we can talk about that. But please put some questions in so that we can have some discussion. So over to Emma.
Hi, my name's Emma Morris, and I'm the perioperative diabetes specialist nurse for Stepping Hill Hospital in Stockport. I'm going to discuss the primary care referrals today. Over 323,000 operations a year in the UK are performed on patients with diabetes. This accounts for 15% of all operations. There have now been a number of national reports documenting the deficiencies in care for patients with diabetes, including the National Diabetes Inpatient Audit, the GIRF, the Getting It Right First Time, and the MC-POD, the perioperative diabetes, the highs and lows. In response to these reports, it is widely recommended that a multidisciplinary approach is necessary to deliver improvements in the quality of the perioperative pathway, and this begins with the moment surgery is contemplated in primary care. As part of this GIRF project, we've completed a baseline audit of a 6-month period of patients admitted for a surgical procedure, and one of the areas we looked at was the quality of referrals. This is just a snapshot of the results from 5 different trusts. And as you can see, diabetes diagnosis is not routinely mentioned in referral letters, and consistently less than 20% of referral letters mentioned a recent HbA1c. That's within 3 months of referral. And this problem is compounded by the lack of integrated healthcare records between primary and secondary healthcare settings. So in order to address these deficiencies, peri-op guidelines have been produced in the form of the JBDS guidelines and more recently the CPOC guidelines. These documents make recommendations for every step of the perioperative pathway from referral to discharge. They were written in response to data showing that poor glucose control in the perioperative period is associated with an increased risk of all complications of surgery. The aims of these guidelines are to ensure that the potential effects of diabetes and the associated comorbidities on the outcome of surgery are considered before referral for elective procedures, to ensure that the relevant medical information is communicated fully at the time of referral, and to ensure that diabetes and comorbidities are optimally managed before the procedure. So the following recommendations of what to include in a surgical referral have been made, include the types of diabetes, the main diabetes care provider, the date of the last diabetic review, HbA1c level within 3 months of referral, a list of all current medications, including the dose and route and any medical devices used, a recent BMI, the latest blood pressure reading, the latest EGFR, and the presence and management of any comorbidities or any complications of diabetes. And it's worth noting that these may be in the patient summary attached to the referral letter. If the perioperative diabetes specialist nurse is made aware that the glycemic control is poor or needs improvement prior to surgery, we can begin to plan for this as early as possible whilst the patient is on the waiting list. This may be before the patient has even had a pre-op assessment. This optimization may be in the form of patient education or medication review, the patient's referred for routine surgery, or a plan of care such as a variable rate insulin infusion for urgent surgery. Also, if we have this information available, planning care can take place remotely, limiting the number of hospital visits the patient may need to take. So here I have a couple of examples of good referrals. The 2-week wait template is excellent because it contains all the necessary prompts for the relevant information. And this example is of a free text referral for elective orthopedic surgery. And just under the black box, you can see there's a couple of sentences that include helpful information such as the type of diabetes, a recent raised HbA1c, what steps have already been taken, and the current medication. So thank you for listening today, and I'll hand you over to Claire.
Thank you, Emma, and it does help if you unmute, doesn't it, when you join these things. Let me just get my presentation up for you. So for those of you that don't know me, my name's Claire Hambling. I'm a GP. I work in Norfolk and Waveney. Kim Howson, who you've already heard, is one of our perioperative nurses working at the James Padgett Hospital, which is just one of 3 trusts within our area. And it's been really fantastic being part of this project. I was really honoured to be asked to be part of the guideline development group. Just perhaps give a little bit of background as to how that came about. We're quite lucky in Norfolk, we've got a lot of passionate people. So as well as Kim, we have Keaton Dotaria, who's one of the consultant diabetologists who works at the Norfolk and Norwich University Hospital. And we invited Keaton to give a talk in one of our local diabetes educational updates for GPs, a number of, maybe just a couple of years ago actually. And I was really blown away by what he had to tell us about the risks associated with attending for surgery for people who live with diabetes. Not just increased length of stay, risk of post-operative wound infections, but actually increased mortality. And that was quite alarming. And he cited a lot of people who were going for surgery where the clinicians who were doing the surgery might not actually have been aware that the individual had diabetes as an underlying diagnosis. And that was really quite a shocking discovery. We then asked Keaton if he would come and talk at the Primary Care Diabetes Society conference, and he was unable to, but he suggested a replacement who was a gentleman by the name of Nicholas Levy, who is also part of the guideline development group. And Nicholas is a consultant anaesthetist at the West Suffolk in Bury St Edmunds. And again, he spoke with enormous passion, which really engaged the audience. So I was absolutely, got into conversations with both Nick and Keaton, and that's basically how I landed up on the guideline group. And what I felt was a real breath of fresh air here is I think it's very easy when something seems to sit in secondary care to assume that the responsibility lies with secondary care, but it's absolutely clear that everybody has a role to play in supporting people through surgical pathways, and particularly those of us who are involved in the longer term care of people with any chronic condition, but I would say importantly with people with diabetes, because the statistics suggest that they are a vulnerable group should they need to come to surgery. I just wanted to draw your attention to the National Confidential Inquiry into Patient Outcomes and Deaths. You've already heard a little bit about the 2018 report, but I'm actually going to take you back a few more years, but not to the very distant past. So this was the report from 2011. You will know that the risk of death or major complication after surgery is actually very low, fortunately. But there are some discrepancies or differences in mortality. So if you are known to be someone who might be described as at high risk, the statistics are significantly worse, much higher mortality rates. And people with diabetes obviously are often or may be high risk, but not always, and that's important as well. So it's important when we're looking at the population of people we look after that we are individualizing and not assuming that everyone with diabetes is a high risk person, but they might be. We also know that because of aging, which is a good thing, we're all living longer, but we're living longer with multiple conditions. So we know that creates a challenge in itself, that how do you manage the multimorbid individual when they need surgical intervention. The other thing that I was struck by in this report, and I was quite shocked because we know that the NHS is a fantastic organisation, works really hard and is widely considered to be a global leader in many metrics, but certainly from the statistics published in this report, there was some suggestion that mortality in perioperative care was actually not as good in the UK as it was in other parts of the world, and notably compared to America. So the chair of the report has actually stated in the report, people die because we do not give them the level of care they're entitled to expect. And that's quite a sort of spine tingling moment really, in that thinking that you know, it's really important that we do something about it. And as my colleagues have said, we all have a role to play, and there are things that we can all contribute. And I definitely believe that primary care has to be a key partner in identifying fitness for surgery. We're the people who support patients in making that decision in the first place. We're the people who make the referrals. And I think it's important that we do that in a very holistic and engaging context, and don't just look to the need for surgery, but actually look for that fitness. Am I doing the right thing by referring this patient for surgery now? This was a schematic diagram that's published within the guidelines, and please do download the guidelines and share them widely with your colleagues. They're very well constructed, so if you're a GP and you just want to know the bit that you need to know, you can go directly to the primary care bit. You don't have to read the whole document if you don't want to. Find the bit that's pertinent to you, and if you work in hospital, similarly, everything's broken down nicely. But you'll see from this schematic, it's very definitely true that in primary care we effectively bookend the entire surgical pathway. We're the people who are responsible for the referral, we're the people who can give the necessary information and detail, and we're usually the people who are responsible for the post-operative care following discharge from hospital. And of course that's not just about wound management, but that's about supporting in a holistic way, including the care of diabetes for people who live with diabetes. Another thing that came with the report, and I think this is enormously important, and Kim and I have been working very hard in Norfolk to try and do this, and this is about making sure that you're engaging as a whole system. So working with your commissioning colleagues, and those of you who are in positions where you can do that, and even if you're not, I would suggest find out who you can link with, go and talk to them about this important piece of work. It's really important the commissioners involved here, because they're often the people who really do support changes or innovation, or supporting with implementation of changes, even for things that sit with primary care or within secondary care trusts. We've already done some work across our system. The project is focused largely around the James Padgett, but Kim has very kindly already spoken at our clinical executive meeting, at our Protect Now meeting, which I'm happy to talk about actually do the Q&A session later actually, Jerry. And we're already engaging GPs, not just in and around the James Padgett and the GPs who refer to the James Padgett Hospital, but across the system. And we've already done some work changing some of our referral pro formas in order to capture all that information that Emma highlighted to you. So I have included the list as well as Emma has, so I won't dwell on that. In terms of supporting preparation for surgery, again, Kim has highlighted much of this, but I think there's a potential as a GP or a practice nurse looking after people with long-term conditions, really to cast a wide net here, make sure it's not just the diabetes you're looking at, but optimizing blood pressure, any other factors such as heart failure, or anything really that's pertinent to the individual. COPD would be another important one. And of course, there's an opportunity when you're having these conversations to really engage in the wider lifestyle implications of engaging with looking after health and well-being for an individual. So particularly weight management and exercise. Smoking cessation would be another important one, obviously. Smokers, as you know, will be much more likely to catch post-operative chest infections and things like that. So there's a number of recommendations in the document. It all makes good sense. It's all things that are within the power of people who work in primary care, whatever your role, to engage with people with diabetes and other long-term conditions to really support them in getting themselves fit for surgery. In terms of the discharge pathway, now for me, perhaps one of the most important thing here is about good communication. My experience as a GP, and it has improved enormously through COVID, I would have to say, and this is just my subjective opinion, but in days of old, we often used to wait quite significant time between the date of discharge and actually receiving the discharge summary. So quite often we would be completely unaware that an individual had had surgery and had been discharged from hospital. And of course, it's really important that we do know that as early as possible. I think it's also really important that it's very clear on that discharge summary who has responsibility for what. So for example, if someone has more complex diabetes and perhaps the diabetes inpatient nurses have been involved in optimizing their care while they're in hospital, that we actually know what is the follow-up pathway. Are they going to be supported from secondary care in the short to medium term, or are they coming back to primary care? And do I, as a GP and my practice team, do we have to pick up responsibility to ensure that we follow up on that and continue to support that individual? It's also important for us to be aware what advice has the individual been given regarding things like sick day rules, what medications have been stopped, if so, for what period of time, when do they need to be restarted again, do we need to do anything such as check renal function before we reinitiate therapies, all those types of things. It must be clear on the discharge summary as to who has to do what and what needs to be done and when. And then obviously the other thing that I think is really important in primary care is very much falls to primary care or practice nurses often to offer support in terms of wound management and post-operative complications. So I think particularly with regards to people who are more likely to be at risk, it's really important that our nurses have the necessary information to know what is it acceptable for them to be looking after, when do they need to refer back to secondary care. So really important that we have good quality discharges with good quality and timely information that helps support the patient pathway. But above all else, I'm going to come back to something that Kim mentioned, which is about embracing the opportunity for a teachable moment. And I think that this sits fairly and squarely with primary care, and particularly perhaps GPs and nurse practitioners, who are usually the people who will refer someone for surgery in the first place. It's a really important moment that you can capture just to discuss with the individual. If they need an operation, and as Kim mentioned, they're usually highly motivated to ensure that you support them with a referral, you get them to see the specialist and they get listed for their surgery. But if their diabetes needs optimize, particularly perhaps where you've been struggling to engage them or they've been struggling to engage or take control for themselves, it really can be a moment where you can work on trying to engage them, get them to understand why it's so important that we improve glycemic control, we optimize blood pressure management, we help them to lose weight in preparation for surgery, all these things. And of course, the benefit is not just for this immediate perioperative period. All of these are things that we know offer long-term health benefits. So for me, if there's one thing I'd like you to take away from this today, it would be about those teachable moments and the importance of good, holistic preparation at the point when you're going to refer someone for surgery, but throughout the pathway. And on that note, I'll hand back to Jerry. But Jerry, I've got a few things we'd be happy to talk about what we're doing in Norfolk if we've got time in the Q&A session.
Okay, well, thank you very much to all the presenters. Thank you very much, Claire. I think one of the really important things is that I think we all must try and consider what it would be like for us if we had diabetes and we're going to surgery. Would we not want to make sure that our comorbidities are best managed before surgery? We focus on the HbA1c, but actually all those comorbidities together have a much greater impact on mortality, and often they're not properly addressed prior to surgery. So we've got a number of questions. One of them comes from Catherine Holmes, who asks about funding of the service. Do we ask the surgical division or pharma? And how were these posts funded and at what grade? I think that's a really interesting question. Quite a lot of the service delivery initiatives that I've put into place, I've not been able to fund them through the trust itself. I've had to find funding by other means. And so our funding for the perioperative nurse here, Rachel, came from our charity funds. We proposed that this would be a good initiative. It would improve the care of people with diabetes going to surgery, and it would deliver benefits. So we audited the whole process and made an agreement that if we spent this money, if we showed better outcomes and saving in terms of length of stay, that the post would become permanent. And that is exactly what happened. And Rachel, who was only a half-time post, the benefits were so great and was seen across the whole division, the anaesthetic division, the surgical division, as well as obs and gynae and so on. They were all for continuing the post and actually to make it a full-time post. Now, one of the hopes from the GIRFT study here, if we can show that this can be transferred to other trusts with the same outcomes, I think there will be no question about whether or not it should be self-funded from surgery, from charity or pharma. It will definitely be a trust initiative to improve the care of their patients and to save them money. So I hope that helps you, Catherine. Claire wants to come in on that.
Yeah, so for me, I think this is, again, one of the important points about engaging the commissioners, actually. Yep. Because certainly our experience in Norfolk, and I'm sure Kim will agree with me on this, but just actually by inviting Kim along to a couple of meetings where we have a full team, not just of clinicians, but our partners in the commissioning team, and for them to hear the difference it would make. It really has resulted in huge engagement right from the top down, including from Melanie Craig, who, as you know, is our accountable officer, Jerry, and you know, and it was very much on her mandate. So when she heard Kim and I present at the clinical executive, she was very much for making sure that we did what we could system-wide from the outset. So hence we've kind of hijacked Kim and stolen her and taken her all over the county in order to talk to people. And I think that is really, really powerful. So again, a plea for those that can, do go and talk to your commissioners and try and engage them with this important piece of work.
But Claire, the key thing here is actually to prove that it works in the first place. And so we were really grateful for GIRFT that they were prepared to invest into this pilot project, which I hope will be beneficial. But certainly within our trust, it made a huge difference. And I think already from the 10 trusts around the country and those perioperative nurses who've been engaged, the enthusiasm to make a difference is fantastic, and we're already seeing great engagement across those trusts. There's another question here, and this I'm going to give to both you, Claire, and probably to Rachel. So it says, do GPs need to refer to DSNs at the time of referral to surgery, or will the patient get picked up preoperatively? Perhaps we should get Rachel to start with that, and then you can come in with a comment, Claire.
Hello, yes, so I think, so do GPs need to refer to DSNs? At the moment in Ipswich, I get my referrals primarily from Clinic 11, which is the outpatient clinic. If GPs want to refer before, then they would still come under my criteria. And that does happen normally via our community nurses. That's how our trust works. So in answer to that, from my point of view, there's no reason why GPs cannot refer straight away before they put through to Clinic 11, or obviously via their normal process through to their diabetes centre for complicated patients.
Yeah, I would absolutely agree with you on that, Rachel. I think if you, I think it's one of those things that because you have that opportunity to start discussions at the point when you make that referral, if you know that there are metrics that need optimization, it kind of makes sense to be starting that from the outset. And if you feel that there's relatively straightforward opportunity to escalate therapies, then obviously go on and do that. If you feel that individual would benefit from referral to a DSN, then I think the sooner you make that referral, the better. The worry always is that not now obviously, but in days of old, sometimes people went through the system a bit quicker than you might have appreciated they would. And the danger then is actually there isn't time, or the surgery effectively gets postponed because there's a need to optimize glycemia. So I think, yeah, the sooner you make that decision and do it, the better, really. So I'd agree.
So there's a question here from Nicole Mottoloni. Nicole asks, have you seen many patients with diabetic foot pathology benefiting from this pathway? Have you found it easy to tie in with the diabetes foot services? Kim's been up and running for a while. I know Rachel could probably answer this, but Kim, have you had engagement with the foot services?
To be honest, we haven't had many patients with active foot problems requiring surgery so far, so I've not really had to engage with the foot services. So I'll probably refer to Rachel for her experience.
Rachel, any comments here?
So in my experience, we have a foot team that's very separate to us, but also has their own diabetes specialist nurse within them, and she will have input right from when they're first referred into the foot team. So and obviously a lot of the surgery will either be very major or it will be over a long period of time, so they've already had quite a lot of diabetic input. I do see them on the ward, but as per preoperatively, very rarely.
Thank you. And Emma, have you any comments on this? Again, Emma,
we're not actually up and running live yet, but from the patients I've seen so far, none of them have had any active foot problems either.
Okay, good. So, Claire, you wanted to mention your initiatives in Norfolk, which are obviously important.
Yeah, so I mean, obviously, the perioperative diabetes nurse specialist is a pilot project, but I think there are things that all systems could be looking at to do just because they make good sense and they are good for patient care. So those are the elements really that we've kind of hijacked Kim to help us with. And we're doing across the system. So things like making sure we have a mechanism for all that important information that needs to go with the referral letter. So we, by chance, at more or less the same time that Kim and I first met, on the same day, I happened to be meeting with an orthopedic surgeon who wanted to tweak a few things on the pro forma for orthopedic surgery. So I thought, well, this is a really good opportunity actually to look at the pro forma and see actually what are the elements that we need for the care of people with long-term conditions and diabetes on referral forms. So as well as doing all the little bits that the orthopedic surgeons wanted, we then did the bits that we wanted in terms of the supporting that making sure that information went forward. And that involved one of our commissioners who was supporting that piece of work. So they're already very engaged, reviewing a lot of our referral pro formas and including a lot of this information, not just for surgical specialties, but actually for some of the medical specialties too. So we're already working on that. The other piece of work that we are just developing, but I think is even more important now than ever it would have been, is looking at the people who are still waiting for surgery. And of course, we know that those waits are particularly long now because of the pandemic. So there's a huge concern that for those people, by the time they come to surgery, they will have been waiting in an extraordinary length of time. So the piece of work that we're going to undertake is actually trying to identify the people on that list who are known to have diabetes and other long-term conditions actually, so that we can highlight those to GPs and primary care services, because particularly now that we're into a sort of new financial year in primary care where a lot of services are trying to stand up QOF again for the year, it would give a list of people who would benefit from early annual review to ensure that their conditions is optimized while they're waiting for surgery. And along with that, we've had support from Active Norfolk, who are going to provide some packs for how you can get fit even if you can't go out and about. So by working system-wide and actually sharing this with our commissioning teams and at our diabetes programme board and our clinical executive, which sits within the CCG, we've been able to do quite a lot that just makes good clinical sense and effectively is like sharing good practice, even for the hospitals where we don't have a designated diabetes inpatient specialist nurse for perioperative care.
So that's great, Claire, and I think that is a really important point for these people who are waiting long. I don't know if you've seen the patient information leaflet, which we have produced together with an anaesthetist up in Manchester, and that goes forward to the patients, saying that you know, prior to surgery, you're going to have potentially a long wait, and this is the time to optimize things for yourself. So these are the things you can access to help you get a bit fitter, to consider your diabetes control and so on. And it really is a very well designed leaflet, which we will be able to actually let people here know about the leaflet. It's going up on the ABCD website, and we'll share that with you as well, Claire. So I think we've got one more question, which comes from Michael Evans. Do you think it would be appropriate for people with diabetes to be prioritized for weight management services while waiting for surgery? I think we would agree with that. No difficulty there. There was another question or a comment really, and that's from Saj Raja. I have a patient with who had an orthopedic knee replacement cancelled on the operating table. Amazing. As the anaesthetist refused to proceed because the HbA1c was 75 millimoles per litre. The patient was understandably upset and complained to the hospital chief, and the medical team had her HbA1c done pre-assessment. Why was this not highlighted before the operating day? Absolutely right. It's not good practice, and this is what we're trying to change. So I hope you've enjoyed that. Can I just summarize by saying that this IP3 project is really hoping to make a difference. It's hoping to show that this pathway, which is patient empowering, will improve the care of people with diabetes. We've certainly shown it in our trust. We've certainly shown it's cost effective. It reduces length of stay right down to the same length of stay with people without diabetes. You probably know that length of stay in surgery is much greater than length of stay in medicine for people with diabetes, which came as a big surprise to me, because the people with diabetes get into more difficulty in the hospital from diabetes complications such as hypo and hyperglycemia or foot pressure ulcers, because of the relatively less knowledge amongst the surgical teams. So that's why we brought in the perioperative nurse as a completely separate diabetes inpatient nurse specialist. And Rachel, who we appointed, was appointed from the surgical team. So it became someone who was already familiar with the surgical team. So I think this hopefully will make a big difference for our patients with diabetes. But the plea to you as primary care is we really need your help as well, because by getting this pathway right from primary care, we have significantly reduced post-operative complications to those patients. So I'd like to thank all the speakers. I'd like to thank Sophie Sheard for setting up the webinar, and I'd like to thank you all for attending. And please, as I said, if you'd like to share the webinar with others, please do so. If you want to know about our patient leaflet, we can certainly make this available. So thank you all, and goodbye.